So they are going to discuss a 2-month-old girl child from Punjab who presented with a history of sweating while feeding from last 3 weeks and respiratory distress from 1 week. You can start now.
Good morning, everyone. Today I will be presenting the admission rounds from HDF unit. Our learning objectives for today would be approach to a term infant with patent ductus arteriosus, the hemodynamics of PDA, and the surgical management of the same. So for our index case, we have Miss K, which is a 2-month-old girl. She is a resident of Sangrur, Punjab, admitted on 3rd of December with complaints of feeding diaphoresis for the last 20 days, increased irritability for 15 days, and respiratory distress for 8 days. Feeding diaphoresis was noted in the form of excessive sweating while feeding, associated with suck-rest-suck cycle and interruption of frequent feeding. It was associated with failure to gain weight. Increased irritability was in the form of excessive crying with refusal to take feeds. Respiratory distress was noted for 8 days, which was in the form of fast breathing with chest indrawing. There was no history of fever with cough, altered sensorium or seizures, bluish discoloration of limbs or the face, abdominal distension or swelling of the limbs, prolonged oxygen support or a stomy neonatal course, persistent vomiting, loose stools, or excessive cry during micturition or blood-stained urine. Treatment history: at private hospital, child was treated as a pneumonia, following which a chest X-ray was done, which was suggestive of cardiomegaly. Following this investigation, the child was advised echocardiography, which showed a 9 mm ASD with left to right shunt with grade 2 tricuspid regurgitation, severe pulmonary artery hypertension associated with right ventricular dysfunction. In birth history, antenatal history was uneventful. The child was a term child, small for gestational age with birth weight of 2.2 kg, born via LSCS and had cried immediately after birth, discharged at day 3 of life, was on direct breastfeeds with smooth perinatal course. There was no history of previous admissions in the past. The child is a second born of non-consanguineous marriage with no history of congenital heart defects. Child was immunized and had received birth and 6-week doses, was of appropriate developmental age. On examination, child had a heart rate of 165 per minute with tachypnea. Saturation was maintained 97% on 40% FiO2. Child had good peripheral pulses and normal capillary refill time with normal BP. On anthropometry, weight for age was reduced, length for age was also reduced. Overall anthropometry was suggestive of underweight with moderate stunting. And in general physical examination, there was no pallor, icterus, cyanosis, lymphadenopathy or edema. No gross dysmorphism or syndromic features were noted. In respiratory system examination, child had tachypnea with subcostal and intercostal retractions. However, there were no crepitations heard. In cardiovascular system examination, the child had a hyperdynamic precordium with visible pulsations in the left fifth intercostal space. A systolic murmur was heard on auscultation. For abdomen, the abdomen was soft and non-distended. Hepatomegaly was present 3 cm under the right costal margin with a palpable spleen. Bowel sounds were heard adequately. Nervous system was within normal limits. So in a clinical database, we have a 2-month-old girl presented with complaints of feeding diaphoresis and respiratory distress. On examination, having features of hyperdynamic precordium with systolic murmur, along with features of CCF. So initial impression was acyanotic congenital heart disease with pneumonia and congestive failure. With these complaints, child had an echo done at PGI and OPD basis, which was suggestive of situs solitus with levocardia, AV concordance with normal relation of the great vessels, a restrictive perimembranous ventricular septal defect with bidirectional flow. RA and RV were dilated with a severe PAH which was not explained by underlying cardiac disease. So for evaluation of PAH, child was advised admission in APC building. Initial course was an ER. In the first 3 days, child was managed for respiratory distress with nasal prong oxygen at 3 liters per minute. Once child was shifted to HDF unit, child was started on heated humidified high flow nasal cannula at 2 liter per kg per minute with 30% FiO2. For CCF with pneumonia, child was given furosemide and enalapril. Along with for pneumonia was given oral antibiotics. For the severe pulmonary artery hypertension, child was advised sildenafil from the cardio OPD, which was given for 7 days. However, despite initial resolution of the pneumonia O2 requirement, we were unable to taper child from HFNC. Hence, CT angiography was planned to evaluate the cardiac defect in detail along with the lung parenchyma. On CT angio, situs solitus and levocardia were noted. There was a 9.6 mm atrial septal defect with a perimembranous ventricular septal defect of 3.9 mm. There was also a PDA which was missed on the initial echo of 4.3 mm from pulmonary artery to descending aorta. No aortopulmonary collaterals were seen. After this CT angio, a review echo was performed by consultant which showed 10 mm ostium secundum atrial septal defect with a large PDA and severe pulmonary hypertension. During these events, child developed lung collapse with pneumonia and day 9 of stay, for which child was intubated and started on PRVC mode of ventilation. For lung collapse, child received chest physiotherapy, and for underlying pneumonia was given meropenem, suspecting hospital-acquired infection. Gradually, we were able to taper the ventilation settings to minimal, and child was shifted to CTVS for management of the patent ductus arteriosus. So this study shows the diagnostic performance of CT as compared to echocardiography for detection of heart defects. So echocardiography was able to detect about 28 of the 30 cases, while cardiac CT was able to detect all of the cases with 100% sensitivity and specificity. So it was superior in detection of quantitative and qualitative evaluation of PDA, along with extra cardiac manifestations. Usually children with congenital heart defects can have extra cardiac abnormalities, which is better picked up on CT. This is another study done in Italy which shows intracardiac anatomy can be better defined with a contrast CT, along with especially in complex congenital heart diseases where the repair can be quite difficult. CT angiography is very important for delineating the surgical plan. Also, high resolution CT which is done in CT angiography can provide valuable information on the lung parenchyma and other changes. So coming to our topic, which is patent ductus arteriosus, it is an abnormal persistence of communication between the pulmonary artery and descending aorta. It is the most common cardiac condition affecting the neonates. The incidence of term PDA is around 1:2000, with represents around 5 to 10% of all cardiac defects, and has a greater female preponderance. So this is some basic embryology which showing derivatives of the brachial arch along with the formation of the PDA. Usually the left aortic arch forms the PDA, distal portion of the left sixth aortic arch forms the PDA, while the distal right portion degenerates. The proximal portion of both the sixth arches forms the main pulmonary artery, and this process is completed by 8 weeks of gestation. There are certain risk factors and associations of PDA. Usually, if a sibling has PDA, there is a 3% risk which suggests some component of autosomal recessive inheritance with incomplete penetrance. Chromosomal disorders like trisomy 13, 18, Klinefelter and Fragile X, along with Cru-Chat syndrome are associated. Syndromes like Carpenter-Cruzon, Smith-Lemley-Opitz and Treacher-Collins are also risk factors for PDA, and other associations include Charge and Waiter syndrome. In environmental, antenatal intrauterine infections is one of the most common causes we encounter, which is rubella. Maternal diabetes and phenylketonuria are also linked to PDA, and drugs such as maternal intake of anticonvulsants or drugs of abuse are also increased risk of PDA. So the underlying pathophysiology is of a simple right to left shunt. The increased flow, the aorta is at a higher systemic pressure, and which shunts the blood into the pulmonary artery, which leads to congestion into the lungs. This increased blood flow into the lungs is again returned to the left-sided circulation, leading to LA dilatation and LV volume overload. Subsequently, due to loss of blood into the pulmonary circulation, there is systemic hypoperfusion, leading to manifestations of lower limb hypotension, decreased renal perfusion, and mesenteric ischemia. In our case, we had additional defects of ASD and VSD, which resulted in more shunting of blood from the left to right side, which can lead to the extra pH which was noted on the echo. So for diagnosis, if the PDA is small, usually will present only with murmur without the classic features of CCF or pneumonia. A large PDA will present earlier with CHF and the typical machinery murmur. On ECG, usually LV hypertrophy or biventricular hypertrophy can be present. The X-ray is suggestive of an enlarged cardiac silhouette with increased vascular markings. The echo usually shows turbulent flow in the pulmonary artery with retrograde flow from the aorta. So this is a echocardiography view, the parasternal short axis, which shows the main pulmonary artery along with the ductus and the aorta. So our unit's final diagnosis was a large PDA with small restrictive VSD with large ASD and severe PAH in failure. For management, irrespective of the age, patients with PDA generally will, it is advisable for they should go closer even if it's a small PDA, because small PDAs also predispose the patient for bacterial endarteritis, and later on they develop aneurysms in the pulmonary artery. Pulmonary hypertension as such is not a contraindication for closure if the shunt is still left to right and there is not severe vesico-occlusive disease in the pulmonary vessels. For surgical management in term infants, usually they do not respond to prostaglandin synthase inhibitors. Why? Because there is no endothelial layer which is has the prostaglandins. So this requires surgical closure usually beyond first week of life. For at most centers now, the treatment of choice is device closure using transcatheter techniques. For PDAs less than 3 mm of size, the closure is performed using various coils, whereas for larger PDAs, the amplizer duct occluder device is used. Surgical ligation is done using a posterolateral thoracotomy. The PDA is ligated or hemoclipped, which is without division. Surgical closure is preferred when the PDA is large in size, tortuous, or when the transcatheter procedure is not feasible. Generally, for infants less than 6 months, an open ligation is preferred rather than the transcatheter procedure. A new and upcoming technique is video-assisted thoracoscopic surgery, which is a minimal invasive technique using thoracoscopes in low birth weight infants, which generally cannot tolerate the prolonged effects of general anesthesia or a large open surgery. So in CTVS course, child was managed for the PDA using a PDA clipping via left posterolateral thoracotomy and was continued on furosemide. As soon as the PDA was clipped, the pulmonary artery hypertension, which was very severe, settled immediately and was extubated on the subsequent day. Currently, child is on room air and direct feeds only. Is being planned for discharge from the CTVS unit itself. So the take-home message will be complex heart defects usually present early and have similar presentation despite there may be varying defects underlying. Although it may seem that all these defects can be diagnosed on echo only, but an adequate history and examination is very important to rule out any critical defects. And along with that, CT angiography has a pivotal role in diagnosis and surgical planning of these cases. For term infants, the treatment of choice is now device closure. If not feasible, a surgical ligation is performed.
Okay, you can join me here and request the